Good morning, everyone. Good morning. Welcome to Alara in the Digital Age. On behalf of Hudson Valley Community College and Fulton Montgomery College radiology programs, I would like to thank you all for joining us this morning. It was just about a year ago when our two programs actually started to formulate this idea of this seminar. We had our ideas focused more on the seasoned technologist, technologists that graduated before the digital radiography was prevalent in the radiologic technology curriculum. Many of us watched as the CR and DR systems were moved into our departments, and although we had application specialists train us on these different systems, if your experience was like mine, no one ever taught me exactly how to use these systems in a way that would benefit my patients both in terms of radiation safety and so I could continue to maintain the quality of images that my radiologist was used to. So that's why we bring to you today two inspiring speakers that will both give us the insight into the digital age and leave us with information that we can bring back to our departments and hopefully put into our everyday practices. At this time, I would like to call upon Hudson Valley Community College's Radiology Club President, Paula Heilman, to introduce our first guest speaker today.
Thank you, Marty. Good morning. My name is Paula Heilman, and as president of Hudson Valley's Radiologic Technology Club class of 2013, it is a great honor for me this morning to introduce our first speaker, Ms. Ann Verschurren. Ms. Verschurren is an assistant professor for the Orange County Community College in Middletown, New York. She teaches didactic courses in radiologic sciences and served as clinical coordinator from 2005 to 2011. Ms. Verschurren has an extensive background in radiographic education and clinical coordination. She holds dual registries in both radiography and mammography. In addition, she holds Masters of Education with a concentration in critical thinking and is currently pursuing her Masters of Science in Adult Education. She is a member of numerous different professional committees and organizations, including but not limited to the following: the Association of Educators in Radiologic Technology of the State of New York, the Association of Educators in Radiologic Sciences, the New York State Society of Radiologic Sciences, and the Mid-Hudson Society of Radiologic Technologists. She has served in many leadership and committee roles. Ms. Verschurren has presented at a number of different seminars, including the ART Prep Student Review Seminars and numerous professional continuing education seminars for the registered radiological technologist. Please join me in welcoming Ms. Ann Verschurren.
Thanks, Paula.
You're welcome.
Those people who have worked with me know that if I've had a little bit of caffeine, I get a little gabby. So I had a tea this morning. So I'm going to set my clock so that I'm not here till 4 o'clock talking to you or talking to an empty room. I want to thank you, first of all, for spending a Saturday morning with me. That's this very impressive turnout. Your campus is beautiful, and I'm very impressed with the technology. I did take a picture of all of this so I can go and shame my college into getting something better for our podium back at Orange County. My talk today is about approaching or rethinking how we make our techniques. I'm not really sure how things go in this part of the country, even this part of the state. So a lot of this is based on my experience. I have currently 11 clinical sites and, of course, 11 different CRDR exposure index scales. So I'm going to just bring a little bit of my experience to you and see what you think about it. This is not carved in stone. This is not something that is solidified in our profession yet, but it's just designed to give you an idea of how to approach technique from a different perspective. So when I was in X-ray school, my artistic background was very helpful to me in classes like positioning and clinical. I was able to relate to bony landmarks and surface anatomy because of the figure drawing classes that I had. But I was never really good or never really a big fan of math. And so I had a hard time relating to exposure class. There was just so much formula discussions and things like that that I kind of shied away from that. And so I stepped back and I really didn't feel like I mastered technique when I was in school. When I went to school, things were a lot different. We kind of learned by fire. I can recall as a junior student in my first semester, I had just done an abdomen x-ray with a technologist whose role at that time was just to sit in the back by the control booth and balance their checkbook or, draw, do the crosswords. And we kind of did everything. And I can remember after doing an abdomen, I had written down the technique and I was all excited that she was letting me do so much, And I got the next patient on the table, and it was a lumbar spine, and I can recall vividly saying to her, I was like at the control panel, like I was at a spaceship, like, okay, now what do I set? Like, give me the next one. And I can remember she pulled her mirror down for a minute and was combing her hair, and she was like, we just did an abdomen. And I was like, okay, don't look stupid. Oh, okay. And I looked back at the control panel, and I thought to myself, what does that mean? And I tried to hide the fact that I had not a clue. I was like, I know I just did an abdomen, but I asked her what to use for a lumbar spine. So just smile and look like you're setting something and think about that. And so I realized that she wanted me probably to set the same thing, I guess. Okay, spine did show up in the abdomen. So I kind of set the same thing. And the image did come out a little bit light. And so I learned that, okay, you can sort of use the same thing and maybe just go up a little. And so that's the way we learned in those days. They didn't explain anything. They didn't tell me that collimation affected that. It was just write this down. So from my personal experience going from that to where we are today with the exposure index values, I feel like I've learned so much about our field. And I feel like I know so much more today about exposure. I know this sounds really weird, but when I was in school, I really didn't have time to learn it. I memorized it, right? You're just given so much volume. It's not until a little later that you go, wait a minute, I think I learned something in school that has something to do with this. So I still like to do positioning because that's very appeals to my artistic sense, but I feel like exposure makes much more sense to me. All those mass-driven formulas that we were made to learn make so much more sense to me now that I'm using technique the way I'm doing it currently. And so I wanted to just say today that digital image receptors have not really changed the fundamentals of radiation protection for the RT or the patient. However, our approach to radiation protection can change a little bit. There's a few new tricks that we can all use to help reduce the dose that we give to our patient. Because CRDR image receptors, or cassettes, don't reach the maximum density, which we're now calling saturation, like film screen technology did, we no longer have that visual cue for excessive dose to the patient. We don't know really when we gave too much. The dark image in the past would provide that cue for us. So since we've lost that visual connection between the exposure factors that we use and the appearance of the image, we have to find another way of making that connection between what we set and what we're giving to our patient. The pixels of a digital imaging system can record hundreds and hundreds of shades of gray. What I learned about buying monitors is that monitor displays of 8 bits gives us 256 shades of gray. And a 16-bit gives us 65,536 shades of gray. How many shades of gray did we learn that the human eye can see? About 30. So first of all, we're wasting our money when we hear those oh, this will give you so much more. There's only so much the human eye can see, all right? So in order to enable the human eye to see the maximum number of shades of gray that it can recognize, processing codes used by the DR image receptors control the visual appearance of the image so that it always displays the appealing range of densities, now called brightness. I'm an old dog, so I'm going to sneak in the word density every now and then. Just substitute the word brightness in your mind, okay? Because no longer are we saying density and contrast. We're now saying brightness and contrast in the digital world. So although there's no longer a visual connection between the technique we use and the image produced, we're going to try and learn today how we can get that back. For the RT, this means that we can be using a little bit more mass than we need to, and will not get a dark-looking image to know that. This is because the plates don't reach saturation like film did. We can keep going and keep exposing with higher and higher dose, and our image will be rescaled to give us a quality image. It's not until way overexposure that we're going to see saturation. It takes a lot more, like I said, to turn an image black. On the contrary, if the imaging plate is not given enough radiation, the image will appear mottled. And I remember learning about model in film screen world, but it was very, very rare for me to see it. Okay? I think that I've seen it a couple of times more in digital imaging than I've ever seen in film screen. And that has to do also with the properties of digital imaging. It tends to enhance everything. We see more trabecula in the bones that we ever saw in film screen. But we also see more grid lines than we ever saw when we made a little mistake on aligning to our grid. Now we're seeing model more because everything is emphasized in the digital world. So RTs need to structure their techniques to avoid this model, and that's kind of drilled into our heads. We want to stay away from model. The disconnection between the finished image and the technique used can be a positive one if the RT uses the manufacturer's exposure index scale to help them form exposure factors that will reduce patient exposure while still producing a high-quality image. Therefore, the very experienced RT needs to rethink their established techniques, and the new RT has to be aware of how they're forming their new techniques. The RT's knowledge base and a historical perspective of where we have been with film screen is key to passing along the principles of exposure to future RTs like the students who are sitting among us today. The experienced RT has to seek out and embrace the new principles of digital exposure so they'll be able to pass that along to the next generation. The technology of today allows the technologist a lot of latitude, which translates into room for error. This latitude when selecting technical factors is something that I've noticed myself. In film screen world, we had to be dead on, or you saw it. Either it was a little dark, but it's okay, or it's really dark, but they have a bright light, or it's a little light, maybe we should do another one. But now in film screen, 1, 2, 3, you're seeing it and it's gone. The other thing with students I've noticed that's different than when I trained, and even just in the past, is we don't spend as much time, I'm going to say this and see if you know what I mean, pawing our images that they used to. Did you ever hang up a film, those of you who learned in film screen, and you touched it, it was so beautiful? Look at this, look at this. And you'd tell the student all about it. It was like on the view box, it was fabulous. Does anybody paw the computer screen? No, they're too busy hanging onto their mouse. It's good, click, 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 click. And the students aren't really getting as much film evaluation time as they did with film screen. Even if it was just a minute or so, I feel we spent a lot more time discussing what was on that screen for each case than we are now. So what the technologist of today needs to do is make that connection again between the visual appearance of the image and what they're setting, so we can avoid what they're calling in our profession now exposure creep. And exposure creep is that tendency to want to stay away from model or the low end of the range and keep it in the higher end of the range so that we know we have enough patient information on there. And that's a good thing, but not if you're getting too carried away with overdoing it. So how do we embrace the concept of image gently and image lightly that we're hearing about in the profession these days. There's a term called Sankofa. It's Salvadorian in origin. It means to go backwards to learn before moving forwards. And what that means for us that have been in the field for a while, we need to take a step back, and although we're really highly experienced and all of our knowledge about technique has served us well, we can actually do a little better for our patients. We can continue on the way we are and produce acceptable radiographic images and be comfortable where we are, or we can push ourselves out of that comfort zone a little and start to rethink what we're delivering to the patient and get on board with that. So those of us who've had a few years on the front lines under our belt, we know that having a reliable set of what I'll call base techniques makes all the difference when the patient is challenging. There's nothing like being confident in what you're setting when you have a trauma and you're dealing with the positioning, because that's what you want to think about at that time. What do I have to do differently to get the same result? You don't want to have to think about, and now what's my technique? I can tell you that my experience with CR and DR is very different than when I first started in this career. Back when I began, as I said, we learned in a totally different way. And not only that, I had totally different equipment. I was hand developing in the operating room with a surgeon kicking the door, saying, you know, are you done yet? And I would say, is it Avon? Pizza. There's no CT then, there was no MRI then, there was no ultrasound then. Now that you know that, don't I look fabulous for my age? So that should tell you a little bit about the technology that I trained with and where I am today. I thought daylight processing was like an amazing thing. If I had only known what was to come, I would have been more probably frightened than I was during the 80s and 90s. So when we were in school, they introduced us to 4 basic approaches to setting technique, and I believe these are still what we teach the students. At the time, computerized systems were like, whoa! I mean, I should have thrown that in too. Yes, we had calculators, but no PCs. So computerized systems were like, wow, the future. It's almost like we're in a spaceship. And the other one was automatic exposure control, or what the old-timers say, not old-timers, I shouldn't say that, more experienced technologists will say, is photo timing. And the variable KV system and the optimal KV system or fixed KV system, which is something I'm going to talk to you mostly about today. So just to look over what some of these are, the programs on the computerized system are loaded during installation of new X-ray equipment. They're calibrated by the manufacturer and your department physicist. What you'll do is touch pictures or words, and here we can see there's a picture of a thoracic spine. Oh, there's that T I had. Thoracic spine. And then over here, has anybody worked with the equipment that has this kind of control panel? This is kind of a popular control panel. You pick the body part, and this is the same thing. You pick a body part in a position. And there is a technique programmed in for that. So these computerized systems are really just a automatic programmable technique book, so to speak. So you don't need paper, it's paperless. You just push something and it tells you a technique. It will tell you a technique whether it's tabletop or it'll tell you what to use for Bucky. So after you're touching these words on the microprocessor, it will select your mass and KV. The installer will formulate 3 base techniques: AP lumbar spine, AP extremity, and AP chest x-ray. Your entire technique repertoire can be based on these 3 techniques. And once they have formed these 3 techniques, they will extrapolate and make techniques for everything else. And so those come up on the screen once you select the body part that you want to x-ray. And the RT also has the opportunity to alter those, either with selecting a large, an average, or a small patient size. They also can alter the KV slightly if you have an increase or decrease in subject contrast. And this may or may not be used in conjunction with your AEC or photo timing cells. The problem with this type of equipment, if you've had this type of equipment in your department, it occurs when CR and DR moves in. The digital company links their system to the existing radiography control panel. So if you never use those techniques and you never, you never set by choosing these kinds of things, and you just set using MAS and KV selectors, what happens is it no longer recognizes what you're trying to do because the manufacturer assumed that you're using the system the way it was intended. I don't know if you've experienced this in your sites, but we have one site where if you press, I'm just going to throw out a technique, it's not necessarily the right one. If you press thoracic spine and the thoracic spine says you should use 80 mass at 80 kV, and you go to set that manually, it totally screws up the EI exposure index number. It will only come out correctly if you press the buttons on the machine. So that has caused some chaos in the departments. If you're not using the control panel as it was originally intended to, these people come in assuming you were, and they link that up to your system. So sometimes that's where the flaw is when you're trying to figure out why isn't my technique working. It's the same one that's coming up on the control panel. It might be the way you're setting it on the control panel. So it's really important that you know your equipment really well. Another issue that affects computerized systems comes from poor equipment orientation. Most radiology departments train their new staff by having an existing staff RT show them the equipment. No one gets the operator's manual anymore. It's all word of mouth. I know that when we get our new cars, we throw that operator's manual right in the glove compartment and take off because that's the most exciting part. And we'll figure it out. There's a go pedal and a stop pedal and stereo. But eventually, don't we want to know a little more about the features of our car? And eventually, we take that book out and we look for something that we want to do. We want to make that car do for us. And then we know our vehicle better, and we can use all the features better that maybe we didn't have in our last car. X-ray is the same way. You'll always know there's got to be a place to set a technique, and there's a go button. But there's probably a lot more features available and a lot nuances that you don't know of about your equipment. And I've noticed that this is a trend in radiology that when I was first hired, they gave you the control panel manual, and you really learned about everything you had to set and how you had to set your equipment. Now it's just, oh, here it is, and if you need to know how to operate it, just ask me a question. So you're really not getting oriented as well as they used to in the past. And so if the person doing the training is not shown how to use the equipment properly, that habit is passed down, and the rest is radiology legacy. It's been my observation that even before CRDR broke onto the scene, RTs who were using this type of automatic programmable control panel, they didn't use these patient size buttons. They just kept it on medium for everybody. And so when they set their techniques, they ended up using the same thing on everybody. And in film screen world, that meant sometimes your image came out a little light, sometimes it was okay, and sometimes it was a little dark. And in the world of radiology, we want to create a standard density, or brightness, so that everybody's images look the same to the radiologist who's reading it, because that makes a difference in how easy it is for them to interpret. And we want to make it easy for them. In other ways, we want to make it hard for them, but because they make it hard for us, and one good deed deserves another. But we want to make it easy for them to read an image, to make a diagnosis for our patients. And so that's our job. That's what we need to do. So this means that the same technique is used on everyone. And what I want to pose is, what does the range of exposure values indicate to us about patient dose and about what we're giving to the patient? The automatic exposure control method, all of you are probably familiar with. We call it photo timing. There's an optical density cell or cells that represent a certain accepted density. Once you have an amount of radiation that gets through the patient and reaches that cell, it will terminate the exposure time. So the technologist still needs to set an MA, and they still need to set a KV, and the only thing that's governed by that photo timing is the time. So there's no longer a need to measure. And that's where that habit of not measuring comes in. Students are always told that they should be measuring and they should be doing things very precise, and then they watch technologists not measuring. But that habit came from using photo timing, because you're not supposed to measure. So as you can see up in this corner, I've indicated all the options of cells. Depending upon your equipment, you can rotate cells and decide which cells to use. You can't really see this too well, but it's the density button which this is also a density button, and this is also a density button. It should remain at neutral, or whatever they've decided is neutral. Could be 0, could be N for neutral. Under normal circumstances, you should only be increasing or decreasing that for unexpected pathology, additive or degenerative disease processes. If, for example, you had that elderly woman who spent all her life talking down at the local pub, she's got 16 kids. I fell the other day coming out of the bar and I hurt my ribs, right? You imagine that scenario? What she got? Black lungs, right? Osteoporosis, and now they want ribs? How do you x-ray that, right? That's your challenge. That, in a phototiming world, that's when you would change your density setting so that you could go down in density for those black COPD lungs that she probably has. So under normal circumstances, it should be set to N. If you're in a department that is routinely setting it to like +0.5 or +3 or whatever they have, there's something wrong with the phototiming and it should be recalibrated, because then you don't have that option to go up when you need to because you're already at that high, part. The crux of my lecture today is talking about variable versus optimal KV systems. Variable KV system is such that the mass for the part is standardized, and you're going to vary your KV for part size change. In the past, this would deliver a shorter scale of contrast, but since contrast isn't controlled by KV anymore, it's controlled by our processing codes, we don't really have to worry about producing a high contrast image when we need to. The other side of the coin with variable KV is your contrast was very haphazard. Because you were changing your KV and it wasn't a set KV, your contrast would change. The optimal KV, your KV is standardized for each part, and your mass is going to vary for part size. I always tell the students mass for mass, body mass for mass, right? Generally, you're going to get a lower scale of contrast with this because you're going to be using the highest KV you can for that part. And you are going to have a greater latitude, or latitude means room for error. And because you're using the high KV, you're going to have less exposure to the patient. And it's also less damaging to your tubes, so your managers should like it because it's going to make your equipment last longer. The other thing I like about the optimal KV system is that all of our formulas are mass-driven. So we change mass for SID, we change mass for grids, we change mass for collimation. And now, if we used a fixed KV system, this makes so much more sense in the world of exposure. The true way to have a variable KV system is very precise. It doesn't mean like, going up 1 or 2. You ever do that to a student? They have something set and they're like, what do you think? And they're all happy. And then you go, I would just go up 2 kV. I don't know why we have to do that, but we just do, right? I can't stop myself from doing it. And I tell my student, I'll do it, and I'll look at them and I'll go, I'm sorry, you're right. And I'll walk away. Like I have to let it go. Because sometimes my favorite number is like 78, and you only put 75, and I just don't know that I can deal with it hearing the beep at 78. So the true way to have a variable KV system means that you start out with a formula. You measure your part, you add 30 kV, and from that, when you're developing your technique chart, you'll change your KV for part size, which includes going from this to this, because the hand is now this much bigger than this, right? And then you extrapolate. So an example would be in the abdomen. Let's say you have a 30-centimeter abdomen. You're going to add 30 kV, so you end up with a 60 kV. And when I was in school, that's pretty much what we used, around 60 to 70 to x-ray an abdomen. We selected a mass that would result in adequate density. I'm not saying that this is the perfect technique. I'm just throwing out an example. And so if you get the desired effect, if the radiologist liked that particular abdomen x-ray that you're showing them for 30 centimeters, then you say, now let's make a chart from that. And you'd add 2 kV for every centimeter larger. And so for 32 centimeters, you'd have 62, 34, you'd have 64, et cetera, et cetera. All right, again, we like to go up in KV from this experience 100 years ago, because people who trained me learned this. And that habit of changing KV a little bit here and there comes from this system. but it has evolved into a hybrid system of just using about anything you feel like, because people are going up in everything. They're not just going up in kV. They'll start out with a certain mass and start out with a certain kV, and then they look at the patient and kind of do a little this and that. So unfortunately, the kVs achieved with this method for CR and DR are really too low. And as I said, there's many people who swear they're variable kV people, but none of them use this particular method. They function by the force. And we really need to embrace, the fact that we need to raise our kV for CR and DR, and that's going to help us lower patient exposure. So all of us in this room understand that a body would require a specific energy photon to penetrate it. Because kV will interact on a cellular level with the anatomical components or elements of the body, the hydrogen atoms, the carbon atoms, the oxygen and the phosphor atoms. The part composition does not change when a person gets larger. The only thing that changes is cell compactness. The basic elements in the body don't change, so the photon energy does not need to change. If you start out with the correct photon energy to begin with for a part, you don't need to change your kV for the position. As you know, any beam we shoot is not homogeneous. There are lower photon energies in there too. So we need to create more photons so we have a larger ratio of desired kVps in that beam to those that will attenuate on the way through. If we create more photons, statistically, we will penetrate the part better, as long as we're at the energy level designed for that part. One of our goals is not to have to worry if an image is going to be dark or light. There are enough variables on that table, and the positions are sometimes difficult for the patients to assume or maintain, so it's better if we don't have to think about technique. An effective technique book or technique chart in the digital age is one that will maintain consistent signal intensity, resulting in an appropriate brightness of the image, and take advantage of features that minimize patient dose. Naturally, repeats are going to occur in radiology because we have to deal with a lot of variables that are not in our control. DR cannot compensate for positioning errors, centering especially, motion, gross over or underexposure, but rescaling software and other algorithms have helped reduce patient exposure by reducing the number of exams that had to be repeated due to errors in technique selection. Manufacturers' range of acceptability is extremely wide now. Those of you who learned with film screen know we had to be accurate here, and in digital world, now we have to be accurate here. So now we have the ability to have techniques out there being used on patients that are really different, sometimes twice the exposure, and yet still within the range of delivering a nice picture, a nice x-ray to the radiologist. We are all aware that repeats are bad, and we all try very hard not to have them occur. It goes against our philosophy of procuring the best image with the lowest dose. But again, there's so many variables that need to be controlled that unfortunately repeats will be here to stay. But a sound technique book and experience is going to help you reduce the overall exposure to the patient, even when we're not talking about a repeat. So how do we reach this? I wanted to ask how you're doing technique, and what are some of the rules of the road in your site? As long as you're in the range, everything's cool? Nobody asked you anything? Nobody ever talked to you about what you're using? As long as it's in the range, it's good? Okay. If it's outside the range at all, do you have to repeat it? No. Right, okay. Is there a technique chart hanging somewhere that everybody uses? Some people are doing this, some people are doing that. You'll like this next slide then. Technique charts are in our departments. Technique is everywhere. I don't know if you have this one in particular, but it might appear in the form of a memo, and then on the side it says, cross-table lateral hip technique, do not erase, exclamation point, underline, right? It might be that somebody has a little book where they have it in their pocket and they wrote stuff down and they're using that. It might appear as a Post-it note on the radiation report that's hanging in the room. It might be written on someone's hand. That's my favorite technique. Don't touch it. All right? And somebody might have typed something out and hang that on your wall, right? So regardless of what you were taught in school, technique is literally all around us at clinical. Sometimes you have to look for it. It might be on the wall. It might be underneath the memo. You know it's a secret one that nobody knows. Pick it up and look at it. Rarely do the technologists, however, have access to a reliable technique chart that is consistently used by every single person in that department. That's the way it used to be in the old days. And what was wonderful about that is if you were the QA person, you really got a sense of when a room started to misfire because everyone was using the same thing. And everybody started to say, like, hey, did you just do an abdomen in there? I just did one in there, and it came out like you do it. And then they would go, yeah, I'm noticing that too. And you could report that to your supervisor, and real calibration issues could be taken care of. Now, with everybody using whatever to get in that range that's like this big, it's a really long time until we notice that our equipment isn't shooting properly. So that's part of the reason that we really need to standardize our techniques, even though that we all have our favorite numbers, and it's really hard not to set that one number. And we don't want to go back to the beginning where we have to remember another number. It is better for the quality assurance. It is better for figuring out when your rooms really don't shoot right. And it is better for the patient because we can all get together and think of a great technique that will deliver the lowest exposure in our departments. Oops. So generally, all technique charts share certain characteristics. The technical factors such as MA, time, KV, SID, focal spot, grid ratio. Sometimes they throw in some angles that are required for views that we don't do too much, like sacrum, coccyx, you want to remember which is which. But as I said, I firmly believe in the fixed KV system because it starts to make a lot of sense. There is an optimal KV chart in the Carlton-Adler's exposure text. And that one was great for Film Scream, and I'm not sure that they've updated it yet. I didn't check this morning. But with technology changes, that scale is no longer applicable. This technique chart that I'm showing you, not technique chart, this optimal KV list that I'm showing you is for digital imaging, okay? And so digital imaging, we're now able to raise our KV levels a little bit. And then by doing that, we now can lower our mass and thus lower patient dose. The optimal KV for CR and DR, you need to buy into that. It was very difficult for me at first because one of my prides in my profession was to be able to produce a really pretty image of bone work, a nice, high, contrasty image. I can remember when MRI came out, I challenged the radiologist and this neurosurgeon that I could show them a bulging, anterior bulge on a lumbar spine, lateral. And they said, no, it's impossible, it doesn't show up. And then they had an MRI result, and I had a lumbar spine, and the same patient, and I showed them it's at L3, 4, whatever, and here it is, and they were like, well, I'll be dipped. And they were amazed, and that was because of the technical factors that I had used on that patient. And it's kind of amazing to me that what we do every day, tableside, really can affect what the radiologist gets off that image and what we can avoid doing, maybe extra diagnostic tests that cost a lot of money. Maybe get treatment faster because something was seen on a radiograph. There are so many people leaving diagnostic imaging for all these other fancy schmancy modalities. Don't get me wrong, I'm studying for my CT boards too. But diagnostic imaging really needs people who are going to use their heads and be creative. Not just creative with positions and trauma, but be creative with the techniques you're using and the way you're approaching your equipment, and really give it your all. And so there's no reason to leave diagnostic. People are kind of looking down at diagnostic tests like, oh, that's all you want to be. There is so much to do in diagnostic and so much to think about that you really are going to do a disservice if you eliminate that from your future. There's nothing wrong with being cross-trained and having a little piece of that digital electronic pie, but digital radiography is also where it's at right now. So if you can accept that the KV listed for the part will penetrate all size parts for that specific tissue, it will allow you to adjust your mass for a patient's size. And I just wanted to draw your attention to what they're saying up here for abdomen. Okay, abdomen, just a KUB or abdomen series for acute abdomen, flat and upright. They're saying 80 to 85 kV is your optimal kV for abdomens anymore. So if you're shooting anything lower than that, you can actually go up now and not lose that difference between the psoas muscles and the tissue next to it, and not lose the outline of the kidneys. And by going up in that kV, you can lower your mass a little bit, and every time you lower that mass, you get to reduce patient exposure. The other thing that's interesting, though, is iodinated contrast material abdomens. Now we're using 75 to 80. So we're no longer having to do that 64 kV thing that everybody liked for iodinated contrast material. We can actually, and if you look at these, they both have an 80 in them. If you want to make your life easier, you can form all your abdomen techniques at 80 kV. And by doing that, you can lower your mass a little bit and save your patient a little bit of radiation exposure. The other interesting thing comes under spines. Your AP spines can be x-rayed anywhere from 85 to 95, and your laterals from 85 to 100. And so if you wanted to, you could make all of your techniques, and I wrote 85 there, but I meant to write 95, I'm sorry. If you wrote all of your, made all your techniques at 95, you would only have to change your mass for the part size, and then you'd have less to remember because you'd just know all spines are done at 85, and then you would change your mass for the part size. And then, I don't know about you, but ribs are one of my favorite things to try and master. And uppers and lowers, they're saying 80 to 90. Does that make your hair stand up, those of you who were 60 kV, 64 maybe? You know, right? Maybe. If I'm getting all crazy, I got to go up to 64. Can't do any more. But now they're saying we can image our ribs with a much higher kV. So since kV is no longer the controlling factor of contrast, because we can window and level, we can use these higher kVs and still maintain that contrast on our final image. So one of the terms that is grossly overused in our profession, and not so much inadequately used or incorrectly used, but a little overused, I wanted to just talk about a little too, so I can really sell you this concept of fixed kV. The body contains many elements. Atoms combine with each other to form the molecules. In the case of hydrogen, that's the blue section. Whoops. That's the blue section here. And oxygen, the green. We've got a lot of oxygen. They combine to form the body's most prevalent element, water. And those two elements, along with the life-defining carbon, which is black, are the three most common elements in the human body. So if we look at the atomic numbers of these elements, they're all pretty much under 10. If we include things like potassium and what's the other one I wanted to say, phosphorus, those are all under 20. If we look to our contrast materials, we get into the 50s and 60s, iodine 53, barium 56, gadolinium 64. So if we're able to penetrate all of those contrast material elements with KVs in the 70 range, you know that if you're in the 80s now, you'll be able to penetrate everything in the body, okay? Sorry. In the old days, when there wasn't the electrical power available, when I trained, there wasn't a way for us to create enough photons to make the density on the image that we needed to. Our highest MA station back there was 400, and we hardly ever used it. We only used it when they brought down the obese patient in the obese wheelchair with the obese rare earth cassette to do an obese abdomen. We don't say that anymore, right? I was just giving you an example of how diversity has changed since I was in school also, because we did have a wheelchair that right on the back said obese wheelchair. That was really nice. I always thought that was nice. And then the rare earth cassette didn't say rare earth cassette, it said obese cassette, right? So in those days, they were like, oh, well, we better use that 400 station. Otherwise, we always use 300. And how many of you are experienced their careers as long as mine who still like dwell on that 300 MA station? Yes. How many students were told when they're told to set some technique to use the 300, right? If you're setting a manual technique, use the 300, or even a photo timing, you just leave it at 300. We have MA stations now up to 1,000. There's no reason to be stuck on 300 anymore. We can get a lot shorter time exposure if we get a higher MA station. But back then, to go back to my point, is we could not create enough photons so that our beam had more of that peak energy in it to get through the patient. We had to go up in energy of the kV because we just didn't have the MA station. So we created a beam with a higher than we needed penetrating power. So we did things like started out at 80. Who does 80, 90, 100 lumbar spine? Come on, I know you do. All right? And they would tell us in school that the reason is, and they'd make up something cockamamie that like, oh, well, you got more bone, you're penetrating, the pelvis is on its side now, blah, blah, blah. It's the same elements as you did AP. So you can still get through it with 80. But what happened is when the patient turned up on their side, it was so much bigger part. We really should be going up in mass, but we couldn't because we were already at 300 at 1, and we'd get motion. So we had to bring that back down a little so we didn't get motion. So that's where the habit of going 89 to 100 came from. But it's not that you need that 100. You can shoot at 100. We saw that on the scale too. But you can shoot all three at 100 if you wanted to now because rescaling will fix your contrast. So if you're going to think of the principles of radiography, at least think of the correct reason why we went up in those KVs so that you can understand how you can standardize your KV and rely on your mass a little bit more. You don't have to be afraid you're not going to penetrate the part because you will. Excuse me. Okay. So now we have MA stations that are up to 1,000. This has allowed us to experiment a little bit with the penetrating power of the beam. What we discovered is that a larger body part can be penetrated with the same photon energy as the smaller body part. We just needed more mass. When we get the proper penetration, we get adequate density. And we'll get an adequate contrast now because we have rescaling to help us with that. But old habits die hard. And so the term overexposed is still used, even though we're all using the correct KVs for the part. We're not out of control. The term overexposed now has less to do with image density and brightness than it does with patient dose. Overexposed now refers to pixel saturation. And pixel saturation is at the opposite end of the scale of model. Okay? So we can infer a lot from our exposure index values and use them to create an image that is acceptable while reducing patient dose and allow window and leveling to give us the ideal contrast that the radiologist prefers to look at. So a change from a lower KV to a higher KV can be hard for some of us. However, CRDR technology can produce the similar results with film screen even using those higher KVs. Processing codes will allow us to determine the contrast, and KV is no longer being relied on for image contrast. I actually read an article just before this seminar where it said that a knee done at 60 kV tabletop can now be imaged up to 85 kV without loss of contrast, tabletop, but with a reduction in 50% of patient exposure. Ribs done at 75 or lower used to be the only way to obtain a decent study, and this article said we can now use up to 95 kV to image ribs, and it gives us about a 42% reduction in patient exposure. And that's a hard thing for us to say because we'll set 95 and we'll hear 64 calling us, right? So if you're imaging at the KVs of yesteryear, it may require you to change the processing codes also so that you can get the correct image data. Sometimes you can do that. There are certain CR systems where you can actually change the relative speed of what your cassette is. at the time you're using it. I forget the name of it, but there is a place for you when you're flashing the histogram that you can change it from a 400 speed to an 800 speed. And so sometimes what I'll do is use my technique, and I'll get these really larger people, and I'm already using a grid, and I'm already doing this, and you know who I'm talking about, the people at the end of the scale who are very unusual patient types, and you're going to get a chest x-ray where you're going to get dark apices, and then they disappear into nothing because they're just sort of Jabba the Hutt. Okay? And in order to create a density that's a little more even, and you're trying to go up, you're really losing your apices. So when you change the speed class, it's almost like you picked up a cassette that's a faster cassette. You can use a lower technique to not burn out that top, and that faster cassette will help even out the tones on the bottom of the lungs. So some of your CRs, you can go in there and change it for one time flashing the histogram. It sets back to the default, whatever it is, usually 300 or 400 on most of the systems. But we had that system for a minute, and I really liked it when I could do stuff like that. We don't have that anymore in the system that I'm using. I'm working on AGFA right now. So if you couple this quest for using a higher KV, along with something else that I'm really not going to dwell on today, but increased SID I wanted to mention. In Europe, they have been shooting at a longer SID since the 80s. My first time reading an article about the advantages of shooting at a longer SID came about like almost right after I was out of school. It was late 70s, early 80s. And I thought to myself, darn it, I wish I knew this then. And the reason that we're shooting at longer SIDs over in Europe is because people, due to nutrition or whatever, are getting taller. But you still only have a 14x17 IR, right? How many of you have tried to pass that abdomen comp and had a hard time with that? But you can do like almost anything else, right? You got one shot at it, right? Are the pubic bones on there and the kidneys on there? Let's just do this and wait for it to come out, right? The longer SID you use, the less what? Magnification. Excellent, all right? So if you can start out by setting your techniques at the longest SID your equipment will allow you to use, you're doing two things. One, you can show off and put a border of collimation on your abdomens because now they're not hanging off both ends. And number two, you're delivering less skin dose. Okay, so there is a reduction in patient exposure, even though you're thinking to yourself, well, I have to go up for the distance. It's, the study was showing how much less skin dose there is, because you're still going to penetrate the part. No, so that's not what we're talking about. We're talking about what gets absorbed in between. And so you actually are losing less patient dose with that. So if you can shoot at longer SIDs, and again, sometimes your equipment is limiting that because they're going to say you have to shoot at 40. 40 is like so passé, all right? If you're not shooting at least 48, you're kind of old-fashioned. And no matter where I've taken a job, all I do is throw it up to the very top. Sometimes I have a hard time standing, and I have to stand on the footstool that lets them on the table in order to do that. But I've found that everybody fits on there now. And I can, you know, look, I don't tell the students that I do that because I just look really good with my collimation around my four-border chest. Psst. And if they're my students, sometimes I tell them, you know, if you bring that distance back a little bit, you'll fit that person on. I have techniques for that person who tells you, just before you shoot their x-ray, they told me to say, I have long lungs. And then that's the worst thing a tech wants to hear when they're just about with the portable, and they say I have long lungs, and you're like, oh, I only brought one plate. So what I do when they say that is I'm like, okay, normally I bring the portable up and park it right at the base of the bed, right? And you can turn it. And I say like, okay, I wheel back out, and wherever the wall is over here, that's where my portable is now. I'm like, all right, I'll yell to you when you have to hold your breath. All right? In one of my x-ray rooms, I actually don't have a detent lock that prevents you from taking exposures. I bring that all the way back to the aprons hanging on the wall. Those people are like, and I get a nice little border on it, and then they say to me, wow, they've never gotten me all on one before. And then again, I go, psst. I might be old, but I got tricks. So some of the principles we learned in school really do carry over into professional practice. And what we're going to talk about next is how we use these EIs, or exposure index values, to help us create those wonderful techniques that are going to deliver less exposure to the patient. The manufacturers, when they come in to talk about what we should do and how we should operate, they tell us, this is the range, shoot in there, and that's fine. Sometimes the radiologist will say, like, okay, well, that's their range, but we're going to make this our range. Have you had that? Sometimes it's wider, sometimes it's more narrow, but they kind of alter it a little. Whatever the range is, that's what they're saying to you is the ruler. That's where we want to shoot. And so we need to realize that there is a place in the range that we should aim for in order to have a more standardized approach to technique. So when you start to adjust your favorite technique, you should consider the center of the range. And I'm sure a lot of you have thought this out and said, makes sense to me, I'll just aim for the center and whatever I get is good, right? And it does make sense to aim for the center. This way, if you have unexpected pathology or maybe a little lack of confidence in collimation because your patient's a little bigger, it won't screw up your EI values. And the resulting image will stay within that established range. So if you're shooting for the middle, something unexpected comes up, you know you're still going to be in there. Is that pretty much the way people are practicing right now? Is that what your experience has been? Or you're not really looking at that at all, you're just using your favorite technique and then you look and you cross your fingers and go, is it in the range? Ladder? Yes? Okay. Laughing, but ladder. Yeah. So CR technology is helping us to reduce repeats. Rescaling is helping us to make images more acceptable. But the technique that you use still has to be the right one. It's still in our hands up till today. But as you can see, the way manufacturers are creating our equipment, if we're complacent and we give up the ability to create the technique that we're giving to our patients, this equipment is going to become so automated that they are going to say, why do we need RTs? Why can't someone else just press this button, right? Y'all hate that button press analogy, right? Because as educators, we make you drink that Kool-Aid right on the first day, right? We don't want to be called button pushers. So we need to really take control of our equipment. We need to know all about it. We need to know all its features. And we need to make our own techniques. Because if we don't do that, someone's waiting in the wings. Some other allied health professionals, nurses, are waiting to take our jobs because they feel, and this has been, I read nursing journals when I'm in the ER working at night, and I've read the words, it is easier to teach a nurse to do x-ray than to teach an x-ray tech to do nursing. And I don't know what world this person came from, that they have created a certain job that people are uneducatable. Is that a word? But how is their perception of us as we can't be taught to do something? I'm sorry, but you're all in school or have gone through school, and I know we taught you a lot. That's medical school for 2 years. 900 miles an hour, millions of facts and fun things to learn, right? Thank God I didn't have to go for 15 years. I would have killed myself. But it is hard to learn x-ray. And if you can teach a nurse to do x-ray, but you can also teach an x-ray to do nursing. I've been told patient care is nursing 1 and 2 from people who failed out of nursing and came over to x-ray. Okay? So I don't think it's true, but there is a perception out there. And the more manufacturers buy into that perception where they have to make things easy for us, then we're going to give up what we've fought so hard for. We've given up our personal lives. We've given up our time. You're here on Saturday morning. Who wants to give that piece of pie to somebody else? Not me. Okay, enough of the soapbox. So, if you create an image that is outside the manufacturer's range to what we'll call the hot side, that image should never be repeated unless there is evidence of saturation. Okay, and in the old days, we called saturation burnout. So this is a film screen image of an image that's too dark. And we used to call that, oh, it's a little burnt out. See, over here, we might have used a bright light or something, but it's definitely too dark. And in the digital world, this is called saturation. And you've seen it maybe every now and then where it's just so black that you try and window and level it, and it's still black. It's just like this whole black blobby shape. That's when you have to obviously repeat. But what's interesting is if we take X-ray out of it and we look at a picture down here, this is the way the picture is supposed to look in digital world. And this is what happens when the pixels are saturated. And you can see an obvious difference in the appearance of that photograph. Well, even if you don't notice this extent of saturation, when you're outside the